principles of orthopedic anatomy and trauma management. We will cover fracture diagnosis, healing, and surgical intervention, a high-yield clinical pathway. The orthopedic clinical pathway flows through several stages, starting with normal anatomy and physiology, moving to pathology and trauma, followed by clinical intervention, and finally managing potential complications. Bone structure includes the compact outer cortex and the spongy inner medulla. Bone turnover is regulated by osteoblast activity, marked by formation markers like alkaline phosphatase, and osteoclast activity, marked by resorption markers like tartrate-resistant acid phosphatase. Pathological fractures occur in abnormal bone due to conditions like metastasis or multiple myeloma. A Morell's score of 8 or more strictly requires prophylactic internal fixation. Stress fractures result from a sudden, intense increase in physical activity, commonly affecting the tibia and metatarsals. MRI is the investigation of choice for occult stress fractures. We compare primary or direct healing, which requires absolute stability and forms no callus, with secondary or indirect healing. Secondary healing allows controlled micromotion and forms a callus, and is the most common physiological pathway. Secondary healing involves 5 chronological stages. Stage 1 is hematoma, followed by granulation. Stage 3 is callus formation, the first stage clinically visible on an X-ray. This is followed by consolidation and finally remodeling. Open fractures involve a break in the skin, with Staphylococcus aureus as the primary infectious agent. The Castillo-Anderson classification, with type IIIC requiring arterial repair, guides management. The immediate clinical algorithm involves administering broad-spectrum antibiotics, surgical debridement, and applying external fixation for stabilization. The Mangled Extremity Severity Score, or MES, determines if limb salvage is viable. A score greater than 7 generally indicates amputation is required, with ischemia time being the most critical factor. For advanced fixation, the Ilizarov ring fixator offers multiplanar stability and distraction osteogenesis. Standardizing orthopedic diagnostics includes specific radiographic views, like the Judet view for the acetabulum and the Mortis view for the ankle. Definitive stabilization for the upper limb typically uses plates and screws, often achieving primary healing. For the lower limb, intramedullary nails or rods are often used, achieving secondary healing. Certain injuries are fractures of necessity, strictly demanding surgical intervention. These include intra-articular fractures, displaced patella and olecranon fractures, which require tension band wiring, and neck of femur fractures due to high risk of blood supply disruption. Non-union, the failure of bone to heal, is classified into hypertrophic, good biology, poor mechanics, and atrophic, poor biology. Hypertrophic non-union is treated by improving mechanical stability, while atrophic non-union is treated with autologous bone grafting. Malunion is healing in an anatomically abnormal position, with osteotomy as the treatment of choice. Avascular necrosis, or AVN, is bone death from disrupted blood supply, often affecting the head of the femur. Causes include chronic steroid use and alcohol abuse. Early diagnosis relies on MRI. Standard X-rays only show changes much later in the disease process. The orthopedic surgical toolkit includes instruments matched to mechanical action, bone-holding forceps stabilize fragments, bone osteotomy shape bone, the periosteum elevator peels the periosteal membrane, and the bone curette scrapes away necrotic tissue or cysts. Orthopedics balances cellular biology, requiring blood supply and osteoblasts, with mechanical stability, requiring reduction and appropriate hardware. Failure in biology leads to atrophic non-union, while failure in mechanics leads to hypertrophic non-union or malunion. To quickly review key points, the most common open fracture pathogen is Staph aureus. MRI is the investigation of choice for stress fractures in early AVN, and the amputation indicator is a MES score greater than 7. Tension band wiring is used for patella or olecranon fractures, and the key bone formation marker is alkaline phosphatase.